So today we will be going over some preliminary suggestions for looking at data aggregation and analytics, and then hopefully spending the majority of our time going through the suggestions, the preliminary recommendations, and breaking them down and discussing them one by one to identify areas that we still need to discuss, that still need further development, potential areas where we need more information from other work groups, and then identifying any barriers that we'd like the GAB to discuss. So clearly articulating what those barriers might be and then potential solutions. Before we get started, let's go ahead and just hear who we have on the line.
This is Chris at Seacoast Mental Health.
Hi, Chris. Welcome.
Patrick Miller with Aero Consulting.
Great. Hi, Patrick.
This is Tom Lambert in the Hampshire Division of Public Health Services.
Right. Hi, Tom.
Geriatrician at New Hampshire Division of Public Health Services.
Great. Hi, Carrie.
Elizabeth Shields, GHHS.
Great. Hello.
And Steve Kelleher, DOIT and Health and Human Services.
Great. Hi, Steve.
Hi.
Jeff Harner from Rice Health.
Great. Hi, Jeff.
Connie Mosher, Rise Health.
Hi, Connie.
And this is Mark Crockett with Rise Health.
Mark. Anyone else on the line? I didn't quite catch that. Sorry.
I was just asking Mark to mute Asta because he had some back noise. That's all.
Okay.
414. Asta, it's Carol from WellSense.
Hi, Carol. Welcome.
34.
Anyone else on the line that you haven't had a chance to say hello yet?
Deb Mullen is here.
Okay.
Hi, Deb.
Evan Frankel with Rise Health.
Hello. Okay, anybody else on the line?
53. Yes.
Okay, we're getting a little bit of feedback. So if you have a chance to mute your lines if you're not talking, that would be great, just to help with, since we are over the phone.
Asta, can you hear me?
Yes.
Oh, that means I'm not on mute. I just wanted to double check.
Oh, not a problem. Okay, so we'll go ahead and get started. Earlier last week, I sent out a PDF with some preliminary suggestions or potential recommendations that might come out of our committee. And the suggestions were developed from 3 different areas. So drawing from our charter and then what the SIM proposal has set forth for us to look at. And then really pulling from our discussion in October, looking at the use case examples and the brainstorming that we did about the potential uses of data and analyzing data. Also the identification of some of the barriers to that, and then for some areas we also got to the point of brainstorming end goals or what that might look like. So taking in both the goal for the work group and the work that we've done together and combining that with what other states have started to take on and what their projects look like, we've put together this set of suggestions or recommendations to really start the conversation about the direction that we're headed and what elements we might choose to include as in the plan moving forward. So again, this is really preliminary, and you may decide to scrap some of these recommendations or suggestions. They may not be right on target, so the goal of today is really to dive into these and to have a discussion about what the end goals really look like, and then to identify any additional areas where we need to have further discussions or where we need additional information or guidance specifically from other work groups or from the GAB. So that's the plan for today. We will walk through the recommendations with a brief overview. We'll go through everything, and then we'll go back and walk through them one by one to have the conversation. So just to frame this, there's a lot of goals and a lot of ambition in these suggestions. And in order to not bite it off all at once, it's drafted in a three-phase approach. So the first phase really recognizes that to be able to develop the details of these suggestions and to get into the meat of what this actually looks like and how you might actually roll it out, we need more than 4 work group meetings to make that happen. So the phase 1 is really about bringing everyone together to design a very comprehensive plan with the details of how all of these components interact with each other and really how they would be implemented. So this may, during the phase 1, may go as far as identifying partnerships or identifying existing relationships that can be used, and potentially selecting a vendor if that might be the best option to go in terms of creating some of these solutions. The second phase, year 2 to 5, is really the implementation period, focusing on the development of these different technologies and then the rollout, with an additional focus on education and support to support these different tools. And then the third year, kind of pie in the sky, grand goals, would be to expand the functionality and the use of whatever is developed, whatever is designed in phase 1 and then developed and implemented in phase 2. In terms of how these are rolled out, I think that's still very much up for discussion, whether this happens through the regional idea, some of these components, or at the GAB meeting 2 weeks ago, there was some discussion of the potential concept of a statewide center to guide transformation in New Hampshire. So whether these options may happen at the regional level or at more of a state level. So to give you a broad overview, and again, this is in the PDF that I sent out, the suggestions are broken out into 3 main areas: data transparency, quality reporting and provider feedback, and consumer engagement, or the patient caregiver side of things. So here's all the recommendations, 1 through 5, and we'll go through each of these individually to walk through a little bit more detail. So starting with the first recommendation, this would, we talked about this last time we met in October, in terms of being able to extract data from existing resources, particularly with the all-payer claims database, the CHIS, and clinical information from electronic health records. And being able to link these data sources really provides the background for the other suggestions moving forward. So this would be some type of multi-payer collaborative coming together to jointly be able to extract this data and to combine it. As part of this, we discussed in the October meeting, one of the barriers of bringing data together was the lack of standardization of how data was reported. So this could focus on a specific data set because this is a very huge undertaking. So this could focus on a specific data set, such as electronic quality measure reporting, for example, and how those metrics are reported, and would come from the multi-payer collaborative. So as different stakeholders are coming together, both addressing how data is being input into the sources that it's being then taken out of. So then the second part of the data transparency suggestions focuses on this open data initiative, which we heard Doris Lott spoke a bit about during our October work group. And then our smaller discussions got into this a bit more in terms of developing an open data site that long-term wouldn't necessarily just be health data, but would also draw on other public sector data as well. So housing, for example, or transportation, or criminal justice. And these recommendations are broken out, this concept is broken out into 3 different phases. So again, that first phase really being the giving New Hampshire time to develop a set of detailed recommendations and what the plan looks like, and being able to use that time to see if the state can potentially leverage existing relationships or partnerships, or make some other type of model to make this open data initiative sustainable. So for example, New York and Connecticut are 2 states that have this type of open data initiative that includes data outside of the health sector up and running. And Connecticut in particular is using a public-private partnership to both be the administrative side of the initiative and also the financial sustainability side of this. So the first phase would be the planning phase in terms of what this looks like and how it could be sustainable. The second phase would actually be building an open data website and being able to have the data accessible, starting first with health sector data. So de-identified information from the CHIS or other data sources such as registries or other public health data sources. And then also including this concept of a clearinghouse of what data sources are available. So if this is a staged rollout, it'll take time to get these data sources linked up with this open data website. And in the meantime, to provide a list of what data are available, who maintains and manages that data, and then potentially a validity score of that data in terms of where it came from and how it's reported. And then the third part of this would be long-term. So once health data, starting with health data, long-term incorporate other sector data, as I mentioned examples before. So then the next set of suggestions focuses on providers and quality reporting. This is, in terms of quality measures, this is an area that we've had a couple of smaller conversations about. We haven't focused on this directly. However, it is part of our charter, and it is a major part of the SIM proposal moving forward. There's a lot of overlap between this concept of quality measures, between practice transformation and also payment reform. Trying to reduce the provider administrative burden in terms of reporting quality measures, and then also with payment reform, when that work group starts to look at different models that are possible, be able to use measures to potentially link with paying for or value or pay for performance. So the first suggestion would be to create some type of single coordinated set of quality measures across payers so that providers aren't having to report on a separate set of measures per payer. And again, this would be decided and established through a multi-payer and provider and multi-stakeholder work group to establish what that set of core measures are. The second recommendation in terms of providers, I'm going to pause this a second. If you have a chance to mute your lines, we're just getting a little bit of feedback or static. Please go ahead and do so. Okay. hopefully that did it. Okay, so the second suggestion for providers is to develop a provider portal, and the provider portal would be used in multiple different fashions. So it would be both a single entry point where providers could report on this set of quality measures across payers, so that providers aren't having to go into different payer portals to enter these quality measures. And then using those quality measures to report performance back to providers, as well as then incorporating the linkage of EHR data and data from the CHIS database to be able to give providers a number of different capabilities. So be able to view patient records across the care continuum, so not just, and this gets into a little bit of when we start to expand potentially into linking to community organizations, and then also specialty providers. So be able to see a patient record across the care continuum within one space. Also potentially providing providers the capability to do some risk stratification analytics and to identify any gaps in care that they may have across their panel. There's a capacity could be built so that providers could look at the total cost of care across a patient's care and be able to use that in terms of some decision-making abilities. So be able to see if they prescribe antibiotics, for example, an expensive set of antibiotics at one stage, if that might result then in a shorter length of stay in hospital down the road and thus overall result in a lower cost of care. One potential capability might be in terms of alternative payment models for providers to be able to look across their panel and look at financial gains and losses depending on what the payment model might be and what the level of risk is.
I was going to send you phone stats every single week, and I haven't.
And then finally, be able to establish alert systems. So potentially set up alert systems when they need to provide screenings or to flag immunizations or any follow-up reminders. So in partnership with this suggestion of the portal, the fourth part of this suggestion is to provide education outreach and support to really encourage the use of this tool and to be able to provide that support and how to incorporate this tool into provider workflows and clinic workflows so that it's actually adding value and not creating additional burden. So then the fifth recommendation focuses on patients or consumers. So patients or caregivers or just general public consumers of information. This concept came up when we were discussing this during our October meeting. The concept of a patient portal, that's a single, again, web-based portal where a patient can view their entire care continuum across multi-payers and providers. So instead of having to log into 3 or 4 or 5 or 6 portals, depending on the different health systems that a patient or an individual is visiting, having a single access point that is then coordinated on the back end. The capabilities build off of what was discussed in October, so again, having that individual information across the continuum, and then being able to see different characteristics of other de-identified, but other individuals that may have similar care needs. So being able to kind of coordinate and see who else is like you out there. The portal may also have additional information, so about conditions or care, and this didn't come up in the work group. This is drawing from other SIM projects. Some other SIM projects are incorporating different types of decision-making tools about potential interventions or tools to help individuals prepare for a care visit or a doctor's visit. and what questions you may want to ask, or what type of information you may want to bring with you. That would be the third area. And then a fourth area might be the capability to compare quality or cost or value across providers, with the broad interpretation of providers, including some type of search capability to be able to look at geographically where providers are located, and then again their corresponding quality of cost of those services. And then finally, this didn't come up in our work groups, but I wanted to bring it up here for discussion, the potential to communicate with providers and or to schedule appointments or be able to be more actively engaged online through the portal. So that's one we'll discuss all of these, but that one is new. And then again, similar with the provider portal, the patient portal or consumer portal, this suggestion incorporates education, outreach, and support for use of this portal. And this, I think, is broad. So in this, we need to discuss whether or not patients even have access to the internet or to a computer to be able to access this. And if not, how do we provide that access point as well? So those are the preliminary 5 suggestions regarding data and data use. Here is the timeline of the phases mapped out. Again, the first phase is really focused on additional development and specification and planning, and making sure that all the stakeholders are at the table, and giving New Hampshire a little bit more time to make that happen. And then the second phase is really the product development and the implementation and rollout. And then the third phase is adding on functionality and potentially different data sources. As part of our charter, as we start to develop suggestions and recommendations, we are tasked with tying some metrics to those recommendations in terms of what that might look like. And so I added in very draft metrics to the PDF that I sent out, and they're really organized based on phase 1, having a plan, phase 2, having the technology of the solution be functional with health data at the end of year 3 to give a couple of years for fixing any bugs or testing by the end of year 5, and then incorporating additional data sets and functionality by the end of year 5. So that's the phase 3. So I want to stop here, and before we go through each of these one by one, get just any general comments or feedback or thoughts on this general approach. And then we'll go back and go into more detailed discussion of each of these to be able to start shape and what these look like, and to identify areas where we need more clarification or more guidance, specific questions from the other work groups. So any general thoughts or reactions to this to start? Okay, so hearing none, I will scroll back up to the first suggestion, and this is the most broad and amorphous suggestion of all of them. So ideally, I'd like to hear people's reactions, suggestions for changing this, different approaches, different ways to view this. These 5 suggestions are intended to start our conversation, taking us from the brainstorming of all the different potential uses and moving us in the direction of starting to say, if we could design some solutions and goals, what form would they take and what would that start to look like? We will then use these to get feedback from the other work groups. And these, I think, will then help fuel their discussions as well. So on recommendation number 1, the concept of having a multi-payer collaborative to come together to support and help create the technical ability to pull information from EHRs and the CHIS database.
This is Deb Mullen. If on that one you're saying that you're going to extract the data from existing sources, are you also creating a central repository for that data?
I think that's a question to you all.
Yeah, because I think extracting is one thing. Where you then put it is a whole other piece of work.
Right. Is there a way to extract the data without having a centralized repository?
What was your question, Asta?
Oh, is there a way to extract the data and to without having a centralized repository?
I think there's
this is
a way
Daryl,
to...
maybe with a query and retrieve by individual organizations, but I mean, I think a repository makes it a much better process.
I mean, why would a repository make it a better process?
Well, I mean, because the query and retrieve process, it would be a delayed process of going out and querying all the potential areas, I would think. I mean, I would think a central repository of data being fed to it would be a much more robust and probably larger group, but perhaps I'm wrong.
Yeah, I think the state of Massachusetts has the ability to query Sentinel health centers, and the Massachusetts Health Department uses it to get public health information, but they're able to go and query, and I think that can happen. Well, actually, the state health department's able to query those electronic health records. The electronic health records, actually, they'll get the notification of it, and those health systems can decline the query, and then the information, if they accept the query, that can get back to Massachusetts back to the Massachusetts Health Department within hours. I mean, they said this turnaround time is typically, under a day. The limiting step would be if the health systems people aren't present to accept the query. But that's just one, counter to the keeping a repository of data.
And are those systems all the same, or are they a diverse group of systems?
I'm not sure if they're all the same. I mean, there must be some way that that state of Massachusetts is able to query, in a standardized format, but I don't know if they're all using the same system.
Yeah, I guess this is Chris at Seacoast. I guess the thing of a central repository versus individual, I'd have to know all the individual databases that I got to query. Whereas if that information is pulled together, you're only going to one spot. So that's what I see as the big difference.
I guess as well, this is Deb again. I don't remember now what number 4 and number 5 are, but it depends on what you're using this information for. If you're using it to do, some type of, you're creating your own reports or doing some stuff like that with the information, if you have to wait a day, you wait a day. If you're using some of this information to assist with patient treatment, then waiting isn't going to be the best thing. So I can't remember what number 4 and number 5 was as far as what it's supporting.
Number 4 and number 5 are the provider and patient portals. So provider portals would be used to support patient care.
Right. So that's where I just, from the querying standpoint, waiting may not get you the information you need timely.
Right, just to throw out there, though, I don't think having a repository would solve that either. So, I mean, typically to do patient care, you want that more real-time anyway, and that's kind of bypassing a repository, unless the idea is that you're going to actually have only one main repository of electronic health record information, which, you know, that's what the VA does. The VA hospitals do, right? They have one, well, I guess they theoretically have one repository of information.
So in order to support, thinking about being able to use this for patients to be able to view their information across the continuum of care, and for providers to be able to use this information for patient care, and then for payers to potentially use this information for programs and alternative payment methods, is are there technical solutions out there that could do that without having to pull the information to one centralized location and store it and create a master patient index?
I think the technology exists. It's just a matter of knowing that the database is out there so that you can go and query it.
And
from a patient portal, I think you'd want it in a central location. Otherwise, you're back to the patient having to log on to each system.
And if you're looking at, yes, the technology exists to develop a master patient index. The problem is that you at least have to store a certain amount of kind of patient demographic data in order to be able to create that master patient index. And that's considered part of a repository, because you'll be storing those basic demographics to do the patient matching. You have to store at least, you know, a certain amount of those. And in one sense, that is one of the problems we have right now from a state law standpoint, that we can't store enough to create a master patient index.
If I could just add, this is Jeff Laughlin from NEO as well. I think there's, to add to that, Deb, I think regardless of whether it's, you know, centralized or decentralized for query retrieve, you have to have that ENPI in the middle to know where to look for the data or how to aggregate it together. But I think when you're talking about, you know, alternative payment methodologies versus for clinical purposes, you know, for clinical purposes, for a patient to take a quick snapshot at their spectrum of health information, the query and retrieve model works fine. The standards are nowhere near ready for that, and I can tell you that even the work in Massachusetts is you know, just barely functional, you know, at best. With FHIR and a couple other, you know, the APIs coming down the line, I think that will ease itself in the next couple of years. And so from a patient perspective or from a clinician perspective, the use of real-time query and retrieve, I think, is much more viable in the next couple of years. But if you're really talking about a payment methodology, you know, you start to look at clinical quality measures. Those are all, you know, done and looked at over windows or periods of time. If you're going to do that centrally, you have to have, you know, really some amount of aggregated data. If someone else is going to run the numbers, unless you're going to let the organizations themselves, you know, submit the measures themselves. But if we want to do that centrally or have access to that, you have to have an aggregated data in the middle to be able to do that in any functional way.
And it's my understanding right now that under state laws that is not possible. Is that correct?
Well, it's a little bit, that is true. Under, you know, the law is a little ambiguous, because NEO, as the statewide, you know, provider of HIE services, is not allowed to aggregate any clinical data. And to Deb's point, you know, although we are allowed to store some demographic information, we're not allowed to store sufficient data to create a valid EMPI that would really work for the level of query and retrieve that we're looking for. Not to say that law couldn't be changed or there may be other alternatives, but right now that's sort of the position of the legislature that from a patient security safety standpoint, they don't want to see the aggregated data or any big centralized pooling of data, demographic or clinical.
This is Tom Lambert in public health, and I think there are models that could work as far as how to get this information into the, let's say, take a patient and patients coming to their portal and they want to aggregate information across all of these different providers or services that may have information about them that doesn't involve an NPI or as some kind of patient identifier. And what happens is that central place that they go to is basically a clearinghouse of the instructions on how they get to all of those different services. And so basically what would happen is that they log into their web browser, go to this central website and start saying, like, I want to see my data, but they would have to basically authenticate to each of those providers at the same time. And there's a lot of contingencies there, but there is a model, I think, where basically that data comes together only for that individual after they've individually authenticated. Now that service could also store their authentication credentials for all of those things, so when they come back they don't have to keep doing it over and over and over again for 5, 10, 20 different providers. So I think it's possible, but I think we're very far away from that type of situation as far as actually being able to pull something like that off.
So in terms of planning, do you all feel like you would need to specify or be very clear on how this happens? Or is it enough to move forward to say that it needs to happen and then to give yourself some time to figure out the solutions and potentially do additional research and what those solutions might look like? So as part of this recommendation, do we need to specify the how?
This is Daryl. I don't think so. I think this that place in the weeds that we tend to get drawn into. So you're probably right. We probably don't need to specify the how.
Okay, thanks, Daryl. Other thoughts on that?
This is Jeff again. I would agree with that. I think getting the data is easy. I mean, and I would just circle back to the very first line. I think just using the word extracting data is a very ominous word because it sounds like we're going in and getting data that doesn't belong to us when all of these systems nowadays can easily distribute the data or send it to us. So it's more about the question is, do we want to collect it somewhere or do we not? And do we want to look at a more distributed model of collecting the data in some way using that type of model? I think that's really the question here before we go too much further along.
And this is an area that we could put out to the other work groups and saying, these are the options, getting their sense, and put forward this recommendation. Again, we can do some wordsmithing in terms of the exact language to not draw any flags in terms of the different terms that we're using. And not specify the how in terms of whether or not there will be a centralized repository, and be able to use the time, so the first year, to flush that out and then plan out what that might look like.
It almost seems like that's what you need. You need the input from the other groups, because I think anything's possible from a technology standpoint in one sense. So it's what do the other groups have for recommendations that should be where the time spent to try to figure out, okay, this is how they want to, you know, what they want. So technology-wise, what do we need to do to put it together?
And part of this our conversation today is to come to a place where we have some draft suggestions that the other work groups can then respond to and say, you know, and to be able to help us morph the recommendations into a collective across all of the work groups set of recommendations that are cohesive and hang together, and so that HIT is supporting practice transformation and payment reform, as well as it's driving some of its own elements as well, such as the Open Data Initiative, which we'll get to in a little bit. So for the purposes of discussion, let's hold on this one and leave out the how for now until we get feedback from other work groups, and then revisit at our next meeting or the meeting thereafter.
And if I could add to that, I almost see, this is Chris at Seacoast again, that you need to break it into two parts, because there's the identified data that would be client-specific and maybe related to care, which brings a whole lot of barriers and stuff into play. But then there's the de-identified data that I think already exists out there under your data transparency that might be a little easier to go at and a little easier to start looking at for payment reform.
Can you say a little bit more about the payment reform piece, Chris, and how that would be easier?
Well, if you're taking de-identified data and it already exists and you can start to pull that together, then people can look at it and start to look at what are best practices, what works, what doesn't work. So it becomes something a little closer. We don't have legal barriers in the way of aggregating the data because it's de-identified. So that, I'm just saying we take it and we look at it as two parts. There's the there's the de-identified data that can be used in general, and then there's the patient-identified data, which is more aggregate for like a patient portal or a physician portal or something, which is going to create a lot more barriers.
And so the next meeting, I'll just put this out there. The next meeting, I think we will need to start talking about the legal barriers head-on and come to some type of suggestion about how the work group wants to address those. So whether no change, whether there needs to be a change in some of the regulations and what that looks like, and for us to forward that up to the GAB. So that is planned in as part of our discussions next week in person, just to put that out there. Because we have been skirting around the issue a couple of times now. So that'll be concretely part of the discussion.
Agreed.
Okay. So moving on to the second part of the first recommendation, so 1.2. This is the standardization of how data is reported. This is more of a placeholder to address, if we're using data from different sources, being able to make sure that that data is actually being reported in common ways. And so it's easier to interpret, and you're getting the same information as it's being reported. So this is a suggestion. It's very broad. This may just need to be rolled into the recommendation 1.1, or I think Patrick suggested in his email today, creating a set of guiding principles, but capturing the fact of being able to address how data is input and what data is input, and trying to create some standardization across that from the initial creation of the data. Ideas or thoughts on this one at all? Is this an area that we even need to be addressing?
It's probably a little early to address the standardization of data that we don't even know what it is we're collecting yet.
I agree.
Okay.
I would suggest too, this is Jeff again, I think that, where a lot of this stuff is certainly from the clinical side and from the claims side, there's already pretty well-defined standards out there, and if we're not following the sort of the national standards that are coming out for EHR certification and, claims data, and trying to create our own, we're just going to be creating more of a mess. So I think there's certainly an opportunity to talk about, slight variations from vendor to vendor for data formats, but in general, especially given what's coming down the line in the next couple of years for the certification of systems and for claims data, we should just be following those national standards.
I would agree with that. This is Patrick. I think, on the payer side as well, they're being asked to provide data to different people, and I think we don't necessarily use national standards for claims data sets, although they do exist, even within our CHIS platform. So I think this is really more of a principle that will move forward, using standards.
Okay, and what about rolling this into kind of the education support, technical assistance side of things?
Well,
downstream, I think it needs to be further upstream.
Upstream.
And I'm thinking if we just change the recommendation to following national standards.
Yeah, it's just the way that we're going to do business.
Okay, so changing the recommendations, and then that'd be very clear. Are there other thoughts on that? Other ideas?
As David from Harvard Pilgrim, I agree in principle, but given what we've had, and Jeff knows this, I think, in Massachusetts, the nuances of the data in the different values and the different elements causes a lot of problems, especially for discharge summaries. So I think it's fine to say that we want a standard, but I think deeper inside that there's a level of data consistency by value or by data element that we need to address. And it speaks to what Jeff mentioned earlier about each EMR system doing things slightly different within the constructs of a national standard.
So not to put you on the spot, David, but do you have suggestions of how to get at those nuances, or a suggestion from the SIM side of things?
No, we wrestle with it in Mass. I think Jeff's organization takes a lot of data in from a lot of hospitals, and they do the normalization and the cleanup of it, and they have tools and techniques internally that maybe they're better able to suggest some tips there. But from my perspective, data off the Mass highway is not that clean, and it's all over the place in terms of the data inconsistencies.
This is Jeff from NEO. I would add to that again. I think we're starting to do that in New Hampshire, at least under the NEO umbrella. That we are starting to bring organizations together to try to normalize the data. Again, we're talking about a sort of a somewhat standardized CCDA structure, but we still see kind of wide variations on the data elements within that structure in terms of problems, methodologies, things like that. I would go back to my original comment that I think over the next couple of years we'll still see a streamlined, normalization of that data. But there's certainly a role for someone like Neil right now to do that work. And depending on what the sort of organizational structure is under the SIM umbrella moving forward, whether that's Neo or somebody else, then I think that those conversations need to be.
Yeah, that's fair. I just don't want to lose sight of it and say, oh, there's a national standard, because it doesn't always fall into that.
I think to that point, we reference multi-payer collaboratives, but I think there's, all of these have a huge multi-vendor, collaborative part of it as well. We're talking about, well over 30 EHRs, in the state right now. Those vendors, this isn't just a payment initiative, and so there has to be some recognition of the EHR vendor community.
Agreed.
Thank you for that. So we're looking at both a recommendation to follow the national standards, and while we're waiting for further standards to come out, also having a strategy to work with both payers and vendors to help normalize the data that's being both inputted and then shared. Does that sound more along the lines of?
Yeah.
A dual focus. And I will say, so based on our conversations today, I will type up a revised version of this that will then again review next week in person. So you should be able to have in the next couple of days a refined version of these suggestions that we can then revise further and also get input from the other work groups. Okay, any more thoughts on either the first 1.1 or 1.2? Okay, we'll move on to the second recommendation, the Open Data Initiative. So this has been a big part of the SIM plan in terms of creating this Open Data Initiative and being able to provide open access, web-based open access to de-identified data for individuals, as we discussed in October, researchers, the general public, policymakers, anybody who has an interest in using the data and be able to have some analytic capabilities to start to play with that data and see different combinations and what that might bring us in terms of research. So New York and Connecticut are currently have functioning open data initiatives that incorporate health sector data, transportation data, criminal justice data, different demographic data. And both use both combine public data sources, and Connecticut is using a public-private model. So the first part of this is using the first year to look at what existing partnerships are occurring in New Hampshire and potential relationships that could be leveraged to create something like this, and then exploring different, for lack of a better word, organizational models that might help sustain this moving forward. This has come, the access to data has come up in a number of the different work groups, including the GAB 2 weeks ago. Although it's not directly tied to payment reform or practice transformation, this is more of a public health, public good concept that's being created that we're working on. Feedback or suggestions? What do we need to be thinking about with this? What else needs to be included? What needs to be taken out?
So this is Mary Beth, and I'm sorry I joined a little late. This seems like this is assuming a central data repository or some sort of central database. And I'm curious how we made that leap to that point.
So, Mary Beth, this is Asta. I would say this is assuming a central website. I don't know that it's a central database.
Okay, so it's more, I don't know if I read this somewhere, sort of that Google of sources of data?
Yes, so that's one idea. So that came up in our work group meeting in October. So it would be a Google, that's the, under recommendation 2.2, that's the clearinghouse of data sources. So what is even out there? And then the way that this is structured in New York and Connecticut is that the data is de-identified and it's pulling from multiple different data sources, and then you can use that to do some kind of basic analytic capacities. So again, the technology, I think the technology and what that looks like, and this kind of piggybacks on our conversation earlier about linking EHR and the CHIS data, the technology of whether that's centralized or not, I think that still can be determined, and that's a conversation that we all need to have.
So this is Jeff again. If I could just ask too, it seems to me that then wouldn't the clearinghouse of, or at least the identification of the data, you said clearinghouse of data sources, but wouldn't we at least under recommendation that the first one, phase one, have to identify all the data sources? Because you are talking about linking them together. I'm not sure exactly how you link together databases that with de-identified data. What's the linking piece that's linking stuff like you down to number 3, transportation versus health versus something else. If it's not a single database, what's used to link these things together if A, we don't know exactly what all these data sources are yet?
Okay, that's a great suggestion. So part of that first part is identifying what information would go into the website. So what data could be drawn from?
Yeah, what are the sources, and what are people? What is it that we think people are want to see? What are the data sources that people are curious about or want access to? And then, which ones would there ever be a rationale to link them together for some sort of analytic capability? And if so, if it's de-identified, how do you do that?
And Jeff, this is Daryl, but just to ring in, you made a very important point there. What data we think they would want to see. I think that's a really important thing from perhaps feedback from the other groups. What data are we expecting to provide? I mean, I think that would probably provide us with a maybe a little more guidance as to which path we should go down.
Okay, this is a question that that the GAB was initially going to start looking at in terms of data transparency, what that actually looks like from the public side to get some more clarification. I don't think that they had time to address it at their meeting a couple weeks ago. We can bring that back up. I can also go, and Doris Lotz would be able to speak more clearly on this. But based on the other websites in New York and Connecticut, I can go and see what data is being provided. And I think the thought is not knowing how it's going to be used is part of the purpose of creating it, is to give people the ability and to be creative in terms of what they're looking at with all these data sources available. And maybe it's not only what data sources, but also the level of details of data.
It strikes me, this is Mary Beth, that building something with the hopes that people will use it is perhaps a bit in reverse of what we might want to do. mean, if we're putting data out there that we hope people will use or we don't know what people will use, seems, I mean, I think we've got to either build in some validation in there. I'm struggling with this one.
Well, and that was my point too, Mary Beth, is that we're talking about collecting data. We're talking about looking at the data, trying to identify, you know, what data to have open, what model to use for the implementation. But we aren't quite sure what that data is yet. And I guess that's, I mean, I'm not looking for the specifics, but if we're looking for a collection of clinical data, and we're looking for, you know, just say, you know, basic things like we're reporting out right now to some of these other organizations, you know, say your quality measures. If that's what we're looking to put together, that's fine. If we're looking for more specifics, like the patient's most recent vitals, radiology images, and lab results, then that's another topic. I think all of those coming together are going to be relevant as to, one, if it's a query, you know, retrieve-based system, if it's a repository. All those factors come into my mind. And once again, I'm trying to avoid getting into the weeds of what we're trying to do, but I can't get past this point.
Okay, so I'm hearing that more clarification in terms of what is the end goal for this would be helpful, and whether that comes from the GAB or the other work groups, or from, you know, I can ask Doris to provide more clarification.
Okay.
I mean, I think New York and some of the others are really focused at some level on transparency for transparency's sake, but I think what I'm hearing from the group and some of my comments earlier is this, that the use cases, we need at least some sense of the use cases, I think, before being able to say we need to do this.
Okay. Well, that is helpful. So I will try and do some additional research. I'll try and contact New York and Connecticut and see how their initiatives are being used and in what cases. If that would help provide some direction in terms of those who have actually rolled this out, where have been the areas of focus and maybe some lessons learned there. Would that be useful?
Absolutely.
That'd be great.
Sure.
Okay. So I'll focus on trying to get that information in the next couple of weeks. Okay, let's move on to suggestion number 3. Again, this is one that we haven't explicitly discussed yet, although we have had conversations around this in terms of administrative burden on providers, in terms of having to report multiple sets of different quality measures, as well as the need in alternative payment methods to use quality measures in coordination with payment and what that looks like. So this recommendation is to create a single set of quality measures across payers. And this is something that some of the other SIM states are doing, bringing people together to decide on a set of 45 measures or a set number of measures that then are being used to drive improvement and for alternative payment methods like pay-per performance.
This is Jeff. I would echo my same comments as before, but I think this is a good idea. I mean, I think again there's a a whole harmonization of measure project going on at the Office of the National Coordinator, and we have to follow the federal sort of guidelines for where Medicare and Medicaid is going with their measures for CMS and so forth. Then there's the layer of the EHR vendor certification and what measures are capable of being tracked, but certainly then at a local level, looking at the local payers, and I'll look to Dave Crucio from Harvard to make a comment, but the local payers, and depending on what local ACOs are looking at in terms of their population health measurements becomes very important. But again, we've got to make sure that we keep the national standards in mind, and we try to align wherever we can with the national CMS standards.
Absolutely, and I think that would be, part of the conversation would be including CMS in the conversation in terms of what measures could be applied across all payers and all organizations using those measures, but in the end trying to reduce the administrative burden. And then as the second part of this is to create a easy access point for providers to report on those measures electronically, so electronic clinical quality measures through a single portal.
I think it would also be helpful, again, to talk about who's going to use these measures. I mean, there's 1,000 literally different quality measures out there from AHRQ and others, so I'm not sure we've really defined yet who needs to get what measures under what circumstances.
Mm-hmm.
And maybe we don't need to know that now, but it just seems like we're saying we're going to, it's just very broad. There's not a lot of distinction in the definition right now.
Absolutely, and some of that's intentional, to be able to give more time, so within the first year, to have those conversations in terms of bringing everyone to the table, and then this work group would focus on hashing out who would be using the measures and what measures could then be applied to meet those different needs, so that we're trying to get away from the hundreds and hundreds of measures that potentially someone could be asked to report on, with a focus on them being electronically reported, as was part of the SIM proposal. Besides what we've already discussed, do you see any major challenges or barriers from the technology side of things of pulling this together and getting the different EHR vendors to create ways to report on a single set of measures consistently?
I think one of the questions that came up, this is Mary Beth, from the folks at my organization is, do the varied organizations in the state have the capability and wherewithal to be submitting data, out of their EHR? Do they have the capabilities, the staff capabilities to do that? I throw that to Daryl, and then maybe some of the smaller organizations that, if we start talking about data extraction and normalization from EHRs, that's a lot of work, and it's some sophistication, and it also costs the organizations money to have those interfaces or those extracts. And so I'm wondering sort of about the practicality of being able to execute this.
Well, Mary Beth, you're absolutely right. I mean, we're dealing with data extractions for ACOs and things like that at this point. And what I've noticed on many of these is these are starting to move away from things because you don't have a central repository. These are moving away from things like interfaces and more towards extractions. And I think that's where the complication comes in, because those are processes that have to run, data has to be validated, and that does take a lot of time. It's definitely a point to consider, probably for all organizations, not just small ones.
Thank you for those points. Part of our discussion next week will start to focus on the use of EHR, and if organizations have the capabilities and different functionalities, and starting to address that aspect of things. So I think in terms of today, if we can get a little consensus or more clarification about where we want to head, then we'll start to discuss and how we get there. And I realize that is difficult in some cases.
So this is Patrick again. I'm wondering if the other work groups are starting to provide some clarity around, sort of who needs what measures for what purposes. I mean, there are payer contracts that need to be managed, and providers would be reporting, to their payers on that. There's a whole sort of consumer perspective around quality, which might be really different. There are already efforts that are going on, in the state, what's working, what's not working. Are the business groups sort of looking at quality metrics from those different lenses, and probably 3 or 4 others that I haven't mentioned just now?
Not quite yet, or they're just getting there. So to date, most of the work groups are, including ours, although ours is a little bit different in that we have multiple different kind of charges. A lot of the work groups have focused on what models they want to move forward on. And they're just now starting to get into metrics and fleshing out what those models might look like. So they've spent a lot of time discussing the different options that are out there and selecting one or multiple options to meet the needs of providers or different organizations and where they're at. And so they're just now starting to get into the more specifics that you're talking about.
Thank you.
And this is Jeff again. I just want to make a comment. I think I've said it a couple of times, but looking at some of under 4.1 to 4.3, almost all of that, the exception of maybe the patient record that could be aggregated across disparate databases with a sort of a enhanced query and retrieve capability. Anytime you're talking about these provider performance reports and risk stratification, that all requires a pretty massive centralized data to be able to analyze that, to provide those reports back. So all of this is already leading the answer that we are looking at centralized data. So I don't know if we want to sort of comment on that in here somehow.
So I think one option that we could do is, get feedback, specifically with the payment reform and the practice transformation work groups, in terms of, giving them all of these different potential capabilities, and then having them highlight or select what is really going to be important and of value, and then having that then drive exactly that question, Jeff.
Sounds great. Thank you.
In terms of going along that strategy, are there any capabilities that we want to eliminate that do not sound good, or any that we want to add in terms of what would be nice to have, or what would help move health and health care in New Hampshire forward at the provider level? Okay, let's turn then to the patient level as well. So it's very similar to the provider level. And there's 2 areas that I wanted to bring up that were new, that were not part of our discussions in October. The first was some patient portals, in addition to including information about potential interventions, are also including different types of tools for patients to use in terms of decision-making or planning tools. So that's an option. And then also providing the technological capability of communicating with providers, scheduling your own appointments, that more of that interaction with providers directly. So this gets back to that concentric circle model that one of the groups developed, with the patient or the caregiver at the middle of the model, and then building out that we discussed the last work group meeting.
This is Jeff. In general, I think a lot of this actually sounds very interesting. I think there's a good need, and I think we've mentioned it in a couple of areas. The national standards for meaningful use, and a lot of organizations are already building their own patient portals. I think you mentioned earlier. Patients have 6 or 7. So I think it does make sense to try to aggregate that in some way, but we have to be very, very careful that we're not, putting too much burden on the practice. Like communication is a good one. I mean, the intricate details of communicating between a portal and a practice EHR is pretty significant. To try to take that to another level, to a centralized portal, is very, very complicated and could potentially very costly. So, having a point of access to help aggregate a patient's portals would be helpful, but we've got to be cognizant really of that, what data could be lost and what functionality could be lost by bypassing an EHR vendor's or an organization's direct portal that's, more tangled, what's that word?
Tethered?
Tethered, there we go, thank you. Tethered back to their EHR system.
I think I had a thought, but it went away. I'll be right back at you.
Any other thoughts, thinking broadly, so thinking beyond the patient portal or caregiver portal, are there other modes or access to data that would be useful from the patient perspective in helping receive better access or better communication or better understanding? What are other technological solutions or options that are out there when we start thinking about the patient and access to data?
This is Patrick again. I think from a patient perspective, it's how to try to find some type of unified way for all this data. Probably most of the people on this phone, if you figured it all out, have 6 or 7 portal opportunities for you and your family today. And I don't know what we can do to kind of buzz through that, but this sort of promise of the longitudinal, health record across providers, across systems, 10 plus years into ONC's activities is still pretty elusive, it seems, from a practical perspective.
I would agree, and I think some states have tried this and not been successful, and many states have incorporated this concept into their SIM models to try again and see if there isn't a way to be able to streamline it and just make access to data simpler and easier to understand for patients, because there's so much information out there. Are there other, assuming that we get some of our other prior questions answered, are there other capabilities that you'd like to see within a patient portal that would be useful for decision making or just general understanding?
This is Chris at Seacoast. If you really want to go out on a limb, you can start looking at a lot of the, I guess I'll call it activity-based data that's getting collected through websites like Garmin or Fitbit, and start pulling that in to a patient or provider portal so you can see what levels of how active a person is. That I think is kind of lost on our generation, but it's becoming big in the younger generations as you look at advertising out there like Microsoft's new health band that they're pushing.
So that's one thing that is not here, but that other some other states are looking at is looking at the ability for patients to upload data and have that be part of. Again, that would have to be some type of shared record, but have that be part of the shared record, both for personal history, health history, intake forms, as well as you could include activity data, as you mentioned, Chris. Okay, any other thoughts on this one? Or any other thoughts kind of in general about these suggestions moving forward? Okay, so for next steps, I will revise some of the suggestions based on our conversations today, as well as draft up a set of asks for the other work groups to try and get more clarification on a couple of the areas that you all identified. And
this is Mary Beth. One thing that just sort of dawned on me, that as we look at building these different sources, either for patients or for providers, that we need to be cognizant of the potential for duplication of data that's in a whole bunch of different places that get pulled in, and how do you manage that? Mm-hmm. And so I'm just throwing that out there of something to be on a parking lot or just to be aware of.
Okay, great. I'm taking notes, and I'll keep track of that. Any other general thoughts or ideas? As always, if anything comes up after the meeting, if some brilliant idea comes to mind, please shoot me an email or give me a call, and we'll try and incorporate for the next workgroup meeting. In terms of next steps, what's coming up, we'll meet in person next week, next Wednesday, November 18th from 1 to 4 p.m. at the McLean Audubon Center. There are directions to this center included in the meeting invite. Invitation that I sent out, and then I'll also include them in the meeting materials that I send out either tomorrow or early on Thursday. Just prior to our work group meeting from 1 to 4, there's an all work group member lunch from 12 to 1. Lunch will be provided. It's open to everybody, and it's meant as a way for you all to be able to have interactions with your colleagues who are on other work groups, to be able to have conversations, do some of that cross-pollination on a more personal level. So please, if you have the time, please join us for lunch from 12 to 1. And then following our next week's meeting, we have our 4th work group meeting in person December 1st. So just after the Thanksgiving holiday, we'll continue discussions, and then we'll potentially have 1 or 2 conference calls after that in December or early January to follow up on any additional items that we need to as this plan starts to come together. I will also say they haven't been scheduled yet, but there will be additional opportunities, webinars, to get updates from the other work groups. I'm trying to provide as much information as I can as the work group information is developed. And in addition, we'll have another series of webinars to help with that as well. With that, I just want to thank everyone for your time today. I really appreciate it, taking time out of your day, and I look forward to talking with you and seeing you all next week. Thank you.
Thank you.
Thanks.